denture staining, isn't it a thing that lets you down, isn't it? Always showing the high smile on which we'll be very careful about. Well, patients that have suffered the trauma of losing teeth in the way that Paul's talked about, and they lose all this tissue, and you make a partial denture, and it's got this candy pink, because you haven't been able to preserve the tissue. You need to put some pink in there. What are you going to do about it? How are you going to produce something like this? And just to show you where we started, that's the patient before we begin. Okay, so how do you do that? Because the teeth are not special. It's nice to use private teeth. You can spend a bit of money on private teeth. But the thing that fools the eye is the pink. Because everybody out there, all the public, know that that kind of candy pink, that's a denture. Whereas if it looks like gums, it can't be a denture. It's the same as twisting a tooth or making the front teeth slightly different colour from the side teeth. All these things you can do if you want to get into the artistry of this. And dentures are an art, believe me. So there we are. Let me show you how we go about doing it. And this is me putting another hat on now, because as I said before, we have a laboratory in the practice that's been a labour of love over the last 5 or 6 years to build that lab, in order to do things the way we want to have it done every time. So they're not compromising it by doing different standards of work, they're just doing it all the same way all the time. And what the lab does, if you can think way back to your pre-graduate days, when you were doing your own dentures in the lab, you would unflask the denture and there'd be little bits of plaster stuck in the plastic. And you'd think, okay, now I've got to get the bits of plastic out, the bit of plaster out before I can polish the denture and finish the denture. Well, the problem with that, if you're staining a denture, is that the stain is surface. So if there's any bits of plaster stuck in the stain, and you take that out, you cut it out, then you're getting rid of your staining, so that's no good. So what the technicians have come up with is using a very hard acrylic material, this plexistone. And what they do is once they've flasked the dentures, they then put this plexistone on top. So it's a silicon rubber that takes in all the detail, all the carving, all the anatomy that they've built into it, you've asked them to do, because it can take them half an hour, 40 minutes just to carve a denture properly so you don't get stripes. They'll then protect it with this material and then flask the thing properly. And I'll show you how it turns out. What they then use are these. You might have seen or come across them before. Stains. There are different types of stains. Kaolin, the original stains, come from the States. And I had to, when I first started, I ordered them in from the States in bulk. There were other materials that we could only get from there. Now you've got Enigma from Shotlander, courtesy of John Besford, you might have heard of. He worked with Enigma to develop these stains. And they all work the same way. It's a sifting technique. It's a sort of salt and pepper technique. I may well speed this one up a little bit. So what you're looking at is, here's the flask. That blue is the silicon rubber. And what the technician does is he's thinking, right, I'm going to have to build this thing up in reverse, colour-wise. He's got photographs that you've given him of the patient, the patient's tissues, the patient's complexion. Ideally, he's seen the patient. So like your ceramist who's building a map of colours, he's going to do exactly the same with his soft tissues. So then he's going to sift in the colours, and you'll start with papilli. And now you can get inventive. Is this a patient that's got a history of periodontal disease? Would we like to put in some red papilli, perhaps? Some deep purple papilli for long-standing periodontal disease and deep muscles. You can start to think about it. You can build in little sinuses, perhaps, if you want to show that there's it is an art. You can start to work on this. So he's putting in papilli, and once he's got the papilli colour and his gingival margins, he might have nice, healthy sort of gingival margins, so he's a lighter colour. He then uses the monomer and will actually wet that, which then kind of lays it down and holds it in position. And then he'll take the next material, the next colour he's looking for, and build that up again, basing it on the map that he's got that he's trying to create. And this process takes him about 10-15 minutes probably per denture. There are other, which sounds like a long time, but the only other technique you've got to do this is an aftermarket, where you've actually finished your dentures and then you're taking composites and you're building them up on the denture freehand. And that's the devil's own job. We know ourselves as like to do a tiny little class 4 composite. You imagine doing a whole denture with composite material, horrible. And it does have a habit of looking stripy. It's like a palomino podium when you're finished. It's a very difficult material to use. This is a nice, easy way to do it. So in fact, let's finish that, because I'm time with the premium. So that's really what he's doing there. And then it comes down to material selection as to how you're going to finish your denture. So you've got the strength that it's not going to break. Are you going to use a heat cure, cold cure, high impact? What are you going to do? You're going to reinforce it. Again, you have to talk to your technicians and see what's available. I can't get away from it enough. And if you find out what the technician's doing and what they've got available, if they haven't got what you want, then find another one. Material we're using now is Palette Express Ultra, Arrayus now producing this material. It's only been out in the market for the last 6 months. This now surpasses all high-impact materials that are out there, and it's a cold cure, and we can use it for anything. We use it for partials, complete, you name it. We use it for our implant bars as well. A lot of the time, and it might sound bizarre for you guys that don't do implants, is we're doing restorations we put in people's mouths we expect to be there for 10, 15 years, that by and large are acrylic, covering a metal beam. So it's like a fixed denture. And we were always told these materials weren't meant to be in the patient's mouths full time. So we need a material strong enough. And this material's been developed for that, but we can use it for everything. And we injection mold. So injection molding your dentures is going to give you a much denser material that's going to have much better flexural strength, isn't going to fracture, it's not going to have porosities. And when the technician gets it right, he can produce things like this. You know, he can spend a lot of time carving. We've got a patient who's a class 3 who didn't want to be turned into ubiquitous class 1. The scourge of the denture maker. Every patient's a class 1. They started off as a class 2, we get dentures back, they're class 1. Class 3 to class 1. Who needs an oral surgeon? You just send them to the prosthodontist. They come back to class 1. Well, this is a lady who'd realised that she wasn't a class 1, she was a class 3, and she quite liked having her lower teeth out front, the top teeth. And that's them in place. And you think, well, what about occlusion? I can't get a decent occlusion unless I do class 1. If you look at the literature on occlusion for dentures, it's smoke and mirrors. Lots of people pontificate about it, but I'll guarantee you, if you get a denture the patient likes the look of, you can forget the occlusion. They don't care. Yeah. Usually, in with the bolus, out with the occlusion. It's not that, it's about appearance. You can do the most beautiful denture, but they don't like the appearance. They'll complain about everything, including the occlusion. So get the appearance right. That's plastics. Let's move on to something else. Partial chromes. Let me just check on the time. Thankfully, we're running out of time, so I don't spend too much time on this stuff. Okay. When I was building this up, I did before Christmas scroll through loads of papers, and I pulled 30 or 40 papers to read through whilst on my exercise bike in the evening. It's the only way I could do both at the same time and not be too bored. And the problem with when you're looking at partial dentures is it's very difficult to get any sort of continuity in a study because there's so many variables. But if I quickly run through these, what we're really looking for is, in this one, basically it comes down to, if you put a denture in somebody's mouth, there's going to be more maintenance, is the bottom line. If you put a denture in somebody's mouth, you're going to lose more teeth, ultimately, as well. How long do dentures last? Bottom line, crowning abutments improve survival. That's a big cost issue, so you really want to crown abutments. If you look at what we're saying, 750 patients followed, 75% survival after 5 years, 50% after 10 years, sounds pretty good. If you look at actually needing treatment on the abutment teeth, and it goes down to 40%, it's not great, 20% after 10 years, but it might be all you've got, but you need to be aware of it. There are conclusions to be had, and let me take you straight to those, because the conclusions are that, first of all, don't do them. Here I'm standing up talking about partial dentures, but my advice to you would be, don't fill the gap if you don't have to. And you're going to start talking about teeth moving, and don't worry about that. We can talk about that another time. There's not enough time to cover that. But the reality is, most of the time, that's not going to be an issue. So if you don't have to do them, don't do them. An SDA is a shortened dental arch. And a shortened dental arch is premolars. Back to the premolars is what the books say. The Kaiser paper I had up there says back to the premolars, which is 2 units on either side. You don't need any molars at all, and you will still have stability in a class 1 occlusion. Class 2 possibly, class 3 possibly not. But I would go so far as to say yes in the papers, but why don't you ask the patient? If they come in with no molars and possibly even some premolars missing, ask them, can you eat okay? And if they say yes, and there's no periodontal involvement, teeth aren't moving, no mobility, no TMJ problems, that's probably a stable situation to the patient. Don't go too fast to try and replace the missing teeth. Not necessary. If you are making one, be sure to upgrade the maintenance program. We all know ourselves, anything foreign that goes into the mouth needs more maintenance. And ideally use virgin abutments or consider crowning abutments. That's a big ask, because now you have to start thinking very carefully about your denture design.